Today, what I'd like to talk about is what common misunderstandings are about depression and anxiety, and I really would like to talk a little bit about what causes anxiety and depression. Because I think if you understand, what causes depression and anxiety, then the treatments that we suggest for it begin to make more common sense. Let me start off with some thoughts that patients ask. I ask patients, what do you think causes depression and anxiety? And I get a couple of common answers that come up. So one of them is difficult situations people are going through, causing stress. People think that's what causes depression and anxiety. Another thought that comes up is chemical imbalance. People have heard that phrase, a chemical imbalance. Other people think that it's like a character flaw. It's a weakness. It's, that if people would just toughen up and suck it up, they could manage their own depression. They could reduce their own anxiety. And that it's really sort of a failing on their part not to manage it. So I'd like to talk about some of these things, but I'd like to put them in the context of a lot of the research that's been done over the years and things that we know. Many times when we're taking histories from people, we want to know if anybody in their family has suffered from depression or anxiety. Some people think, maybe that's because if you grow up with people who are depressed, they're going to make you depressed. Or if you grow up with nervous people, and anxious people, they're going to make you anxious and nervous. There may be some truth to some of that, but what's really important is some of the what we call epidemiology research. So epidemiology is the area of medicine that studies the prevalence of diseases, where different diseases and disorders occur, and one sub-area they look at is the area of genetics. So there's been some really interesting research done over the years that, for example, looks at how commonly people within families may experience depression or anxiety, like other disorders like diabetes or arthritis, or any of these conditions inherited. And we know pretty commonly that if diabetes runs in a family, people know that maybe there's a genetic link to that, and it's a greater chance that, if you have a parent or a first-degree relative, you may have a higher chance of developing diabetes. Well, we know that about depression too. We know that the more closely linked somebody is, in other words, first-degree relatives as opposed to second-degree relatives. What's a first-degree relative? That's a mother, a father, a brother, a sister. What's a second degree? Maybe an aunt, an uncle, or a grandparent. We know that the more closely somebody is biologically related to someone else, that the DNA that they inherit is more closely aligned. Everybody's heard about DNA studies, right? Reading crime novels and tracking people's DNA, or paternity suits, looking at the DNA correlates of that. But we do know that the more closely linked someone is through DNA, the more likely it is they're going to, in fact, have depression if that other person has depression or anxiety. And I'm talking about anxiety and depression together because as we talk about this, you'll see there's a link. I often say they're like a horse and a carriage that go together. There's a high percentage of people who suffer from depression suffer from anxiety. There's a high percentage of people who suffer from anxiety who suffer from depression. The most genetically linked people are identical twins. So one of the things we look at are concordance rates, what are called concordance rates. A concordance rate is what's the chance of a person having a disorder, say depression or anxiety, if they're identical twin, if an identical twin with the identical DNA has it. And we know that the correlations are really high. So if one identical twin has it, so does the other. Well, people say, well, maybe that's just because they grew up in the same home and environment. But we know from some Scandinavian studies, so Norway, Sweden, Denmark, these are people who keep great health records. They keep great adoption records too, that if people are adopted at birth into different homes and raised differently, without even knowing about the existence of the other. If one of them develops depression or anxiety, there's certainly a very significantly higher chance that their identical twin will develop it too. So we know that there are genetic links from the epidemiology work that's been done. Over the past, 15 years, there's been a big international study called the Genome Study that's been done. And that's looking at kind of the DNA attached to people of different cultures, looking at what happens to our DNA over the years. One of the things it looks at is, are there any genes that we can isolate and see that seem to correlate with different medical disorders? So can we locate the genes that code for diabetes or arthritis? Can we look at see if there's any genes that seem to correlate with the prevalence of different disorders? And looking at the genome studies and some of the research that's been done, we have been able to isolate specific genes. These are little areas on our chromosomes that code for disorders, and in particular for depression and anxiety. We've actually been able to find 4 gene sites that code for depression and anxiety. So not only do we know that there's a genetic legacy, but we've also begun to uncover some of the genes that are associated with the development of depression or anxiety. We're moving it into an area that begins to underscore the importance of biology as opposed to just a character flaw, or somebody not just sucking it up and dealing with the stresses and pressures of life. So the epidemiology and genetic research are underlying that biological connection. Now, we've also got another area of research, and that's an area of research called diagnostic imaging. What's diagnostic imaging? Well, that's taking of an image or a picture of our bodies and look in a way that's clinically useful. So an X-ray, for example, is the most common one. Unfortunately, X-rays of the head and brain haven't shown us any differences between people who suffer from depression or anxiety. But the new diagnostic imaging studies that we have available to us are showing some interesting indicators. One is something called a PET scan. So what's a PET scan? PET, that stands for positron emission tomography scan. Some fancy words. What does a PET scan do? Well, a PET scan is based on a principle. The principle is that glucose is one of the primary fuels that our body uses. And whatever part of our body is being used at a particular point in time is likely to be utilizing glucose. And the brain in particular uses glucose as its preferred energy source. If we attach a radioactively labeled molecule of glucose, or a radioactive molecule, to the glucose molecule, and we inject that into someone's veins, it's a safe dose. It's not something that's going to cause them damage. And we then put them in a piece of technology that basically is like a Geiger counter that's picking up where the radiation is being emitted from. So wherever the glucose is going with that little radioactive label will begin to concentrate in the parts of the body that are using glucose. And we can do that with our brains. We can put it in that kind of a Geiger counter-y scanner. And we can look at where the glucose is accumulating in the brain, which is really interesting. So we can find out what parts of the brain are functioning to do different things. So if I ask you to do a math problem and put you in that kind of thing after injecting radioactively labeled glucose, then the part of your brain that's working, doing the math problem, will begin to accumulate the glucose. And we begin to see increased radiation being emitted from that part of the brain. Or if I ask you to read a story, a different part of the brain. We can determine, what parts of the brain are in fact being utilized. Well, when we do this, when we're looking for people who are suffering from depression and anxiety, we are seeing some differences in these people's brains from the glucose concentration in the brains of people who don't suffer from depression and anxiety. So here's a model of a brain. So I'm gonna use this just to explain this to you. But here's the front of the brain, here's the back of the brain here. It's brain sliced in half. People on my inpatient unit say this is my half a brain. Maybe that's all I have. We're looking at where does the glucose accumulate. So I'm going to talk to you about a few different parts of the brain. I'm going to talk to you about the function of these parts of the brain as far as we know them at the present time. If we look at the front of the brain here, so I'm going to use a fancy term. This part of the brain is called the dorsolateral prefrontal cortex. So what does that mean? Dorsal means on the top, lateral means to the side, prefrontal, very front. So this part of our brain here, so right here, right? This is the executive center of our brain. So as I'm talking to you right now, this is the part of the brain that's processing the information that I'm providing to you. One of my autistic patients who gets fixated on American politics, when I talk to him about his brain, he says, Dr. Brown, this is like the Oval Office. This is where the president resides. It's exactly. This is where the executive in us resides and makes executive decisions. Now, we know when people suffer from depression and anxiety that the amount of glucose that accumulates here and is utilized actually is reduced. So that's cool. So maybe when you're depressed or anxious, you're not thinking the same way. Maybe you're not thinking as logically or as rationally. So you're going to have irrational ideas or thoughts like, I'm worthless, or life is meaningless, or make you feel guilty even though you've not done anything wrong, kind of an irrational conclusion. So, reduce glucose, going to this part of our brain. If we look at the brain sideways here too, inside the brain, you can see this little pink structure here. It's a pink structure within the pink structure. Looks like a big fat nightcrawler or worm. And this is called the cingulate gyrus, and it's responsible for all kinds of different things. But we're more interested in the front part of this, because the front part of this, and they call it, being at the front, the anterior cingulate gyrus, this part of our brain has reduced glucose concentration as well when people suffer from depression or anxiety. So what does this part of the brain do? Well, we know this part of the brain is is connected to emotional processing. It's a part of our brain that processes emotions and feelings and connects them with events that are happening right at this moment in time. I say to patients, you know, if I was to walk into the room when you were admitted to hospital asking for help, and I were to say to you, what are you doing in the hospital? You know, why do you need to be here? You've got a life, you live in Oakville or Burlington, you live in this wonderful place. What have you got to be depressed about? You know, go home, suck it up, and go back to school or go get a job, and don't bother me. Your experience of me is going to be interesting. You're going to start to have feelings connected to me. You're going to start to think, that guy's a jerk. Where did he get his medical degree from? Why do I, or God, I came to him for help as a last resort, and now he's telling me to get out of this hospital. Like, I'm at the end of my rope. I got no other place to turn. And I'll start to feel more hopeless. So I start to have these experiences. And these memories, these emotional memories, are really getting coded in this anterior cingulate gyrus. This part of our brain has reduced blood flow. So we're not processing emotions as well when we're suffering from depression or anxiety. There's another part of our brain that's back in here by this white area here. It's called the hippocampus. It doesn't look like a hippopotamus. It's a they call it a hippocampus. And we know this is where our longer-term memory banks are. So our long-term memories reside in here. So immediate memories up here in this anterior cingulate gyrus. And it would appear that the memories that get created up here get transferred down to our hippocampus. And these are our longer-term memory banks. So if I were to throw you out of the hospital and then, 2 weeks later, you're downtown, with a good friend, and then you happen to see me across the other side of the street going to Starbucks for a cup of coffee, and you say, gee, that looks like Dr. Brown. And then you tell your friend, he's a real jerk. he couldn't help anybody. Right? That memory, and then all those feelings you had when you were in the hospital and I'd thrown you out, will begin to come flooding back. You'll get angry all over again. You'll start feeling hopeless all over again. You'll start re-experiencing all that. We really believe that these memories that occur during the day in the immediate time get transferred down the hippocampus, probably at night during dream sleep, rapid eye movement sleep, when the memories are going back and then the little librarian, the hippocampus, is organizing them, attaching them to fragments. Because dreams are kind of weird. So in dreams, this executive center of our brain, dorsolateral prefrontal cortex, is kind of shut off. But these memories and feelings get attached. So we have fragments and storylines that run through, and they're crazy. They don't make much sense to us when we're dreaming them. You wake up and think, oh my God, because you may be sitting down with your friend of 1 minute, and the next minute you're in an airplane, and then your mother's outside on the wing. It's like it makes no sense. But it's because this little librarian is attaching these memories that are forming during the day in the anterior cingulate gyrus to some sort of connecting to things that make sense to that librarian, using their Dewey Decimal System in the hippocampus to organize things, make a dream. But that's where our longer-term memory banks are, and those things affect our mood. They affect how we experience things. We know that the hippocampus has reduced blood flow as well. So longer-term memory is impaired. So we know if you suffer from depression or anxiety, many times your memory's not good anyway, and the memories you do have are all the negative ones. You don't remember the good times. You don't reflect on the good old days. It's always the bad old days and everything that's gone wrong. Now there's another part of the brain that's right at the tip here of the hippocampus in this area here, and it's called the amygdala. So amygdala is a Greek word for almond. I like that word, amygdala. How's your amygdala today? Bet you didn't think about it. What is your amygdala? Well, your amygdala is kind of the body's sentinel system. It's important as well for emotional processing, but it's responsible for tracking indicators of stress. So what can that be? Well, when we're under stress, our bodies secrete stress hormones. Our body secretes them from our adrenal glands that sit back here on tops of our kidneys. These stress hormones are very useful. Nature gives us these stress hormones because these stress hormones help dilate the blood vessels in our arms, our legs, our heart, and our lungs, so that we can run faster, so that we're stronger, so that we can fight. So these are stress hormones that help coordinate the fight or flight response. Most of you, I think, have heard of that. And they're great hormones for that reason. But when we're under stress, we're getting a lot of those hormones secreted. And this amygdala, it really kind of processes. It looks at the cortisol and adrenaline that's coming through. We know when people suffer from depression and anxiety that there's more glucose metabolism in their amygdala. So this is interesting. There's more blood that's in fact flowing through it. More glucose is being activated. Now, I want to talk about another part of our brain that's back behind the amygdala, but closely connected to the amygdala. And it's called the striate body. And you can't see it on this cut here. You have to drill a hole down in here because it's further inside. What does it do? Well, it's the pleasure center of the brain. So if you think of your favorite food, maybe it's pizza, right? And, the kind of food that you might like to eat on a Friday night after a stressful week. Well, pleasure is experienced there. When you have sex, that a lot of blood flows through your striate body. When you're eating favorite foods, a lot of blood flows through there. We know that when people suffer from depression or anxiety, there's less glucose metabolism in the striate body, which seems to make sense because if you're depressed or anxious, then you're less capable of experiencing pleasure. Conversely, if you've had a really bad week and you've been stressed and you sit down on a Friday night and you have your favorite dish and that pleasure center of your brain is tickled by doing the things that you like, then more glucose is going to get metabolized by that. And conversely, less glucose starts to get metabolized by your amygdala. So everybody knows we have things called comfort foods, right? What I mean by that? Comfort foods are things that make you feel good. And there's some rationale to that. But when people suffer from depression, that part of their brain just can't get tickled as easily, even with doing things that bring them pleasure. Nevertheless, doing things that bring you pleasure when you're having stressful times is useful. And in fact, becomes a coping strategy. Not that I want everybody going out having 10,000 calories on a Friday night after a stressful week, but it's something, you just understand the correlation. Understanding with depression and anxiety, we have less glucose metabolism there, and we have more glucose metabolism in the amygdala. Glucose metabolism also correlates with blood flow. So to get the glucose there, you got to send more blood in that area. So as I'm talking to you about reduced glucose in the dorsolateral prefrontal cortex, your executive center, the Oval Office, then we're getting less blood flow. The anterior cingulate gyrus, we're seeing less blood flow and with less glucose. With the hippocampus, less blood flow along with less glucose. With the amygdala, more glucose and more blood flow. With the striate body, the pleasure center, less blood flow, less glucose being metabolized. And there's another part of our brain back down here called the thalamus, back behind the maw. If we drill another hole down, we know that there's less blood flow to the thalamus too. We're not sure of all the things the thalamus does that correlates with depression and anxiety, but we know something's going on. So now, taking this back, just stepping us back a bit, we know that genetics is important we in fact even know what gene sites are coding for depression or anxiety. We know through the diagnostic imaging studies that we're getting physical changes occurring in the brain in terms of reduced glucose metabolism, or in the case of the amygdala, increased glucose metabolism. We know we're getting changes in blood flow. And we have different parts of the brain that are involved when we're dealing with depression and anxiety. That our mood and our ability to control our anxiety is being regulated by these multiple parts of our brain. The executive center of our brain, the immediate emotional memory center, the longer-term memory centers, the sentinel system in the amygdala that's monitoring how much stress we're under, and the ability to experience pleasure along with this thalamus. So depression or anxiety are really being regulated by some sort of genetic control perhaps, and most likely, and that depression and anxiety are biologically based disorders. I often say to people, we shouldn't have named these disorders depression or anxiety because we use those terms in everyday life. We talk about, I'm a little depressed today, or the weather's depressing, or the stock market's depressed. Because when we use those terms like that, or I'm feeling anxious, or he's just an anxious person, oh man, that's anxiety provoking. We use them in a way that makes us think that anxiety and depression are not medical disorders. But when we understand some of the science behind depression and anxiety, we begin to realize actually they're medical disorders, they're physical disorders occurring within our brain. And so I say we should have called them something different. We should have called, depression von Stügleberg's disease or something, Because if you said, oh, how are you? I've got von Stügleberg's disease, people will start saying, oh, gee, what's that? They say, well, I'm depressed. People start thinking, oh, yeah, depressed. You just need to pull yourself up by your bootstraps. So we need a renaming, but certainly a new understanding of what depression and anxiety both are. We've got some other diagnostic imaging data that's coming out using a new diagnostic imaging device called the MRI, magnetic resonance imaging scan. We all know what that is. It's another form of an X-ray that's based on the fact that if we put any part of your body into a magnetic field, you know that opposites attract in magnetism. So if the positive ions in our body get attracted to a negative pole in the magnetic field, and the negative ions in our body get attracted to the positive field. And we do that, we put any part of our body in terms of that magnetic field, that all these little ions get pulled apart, and in fact begin to emit an electrical signal. If we put a receptor around it that picks up what that electrical signal is, and then take a computer and convert that into a picture, then we get a picture of the brain. Well, we can even move the magnets around, and the really fancy new MRIs that have been developed, called functional MRIs, we're actually able to move the magnets around, and we're able to focus on different, what are called neurotransmitters, different hormones in the brain. What's a neurotransmitter? It's a hormone. What's a hormone? A hormone is a messenger that passes a message from one cell in the body to another cell. So everybody knows about estrogen and progesterone and testosterone. We all like to talk about those hormones. They're very common. But they're just messengers that are passing a message from one cell in the body to another cell in the body, telling it to do something. So our sexual hormones cause sexual development in us. Our thyroid hormones send messages to cells how to start to burn fuel more rapidly. In our brain, we've got hundreds of hormones. We know that, this gets back to some of our genetic research. We talk about the genes, these 4 gene sites that we've been able to find. We know that those genes can code for how much of these hormones get released within our brain, and that people who suffer from depression or anxiety don't seem to have enough of those hormones getting released. These hormones are serotonin, noradrenaline, dopamine, glutamine. These are good hormones in that the more you have of them, the less likely you are to be depressed or anxious. And the less you have of them being released, the more likely you are to suffer from depression or anxiety. When we use functional MRI scans, they can actually begin to focus upon the specific hormones and the concentration of them in different parts of the brain. And so some of the new research is showing that there's reduced hormone neurotransmitter release occurring. And this is correlated with people feeling more depressed or anxious. So again, new diagnostic imaging data showing us again that depression and anxiety are biologically based disorders that are mediated by the release of these hormones in our brain. The next question is, how do the hormones work? What are they doing? I've talked about different parts of the brain that are involved in regulating your mood and anxiety. Well, we also know that these parts of the brain send messages to each other by releasing hormones. So I'm going to just show you a picture up here on the whiteboard behind me about cells and nerve cells, just to give you a little bit of a picture of what we know seems to be happening when hormones get released. What we're talking about is how do these brain chemicals, these hormones, message each other, because they send cells, send messages to each other. So most of you remember from biology in school that there's a cell that looks like this. There's a nucleus, and then there's this cell, the cell membrane around it, and also there's different things inside the cell. But I want to focus on something called the storage containers, the vacuoles that are inside the cells. And most of you remember that from high school biology, right? Now, brain cells are similar. They're very similar, but they're a little bit different. Brain cells look like this. They've got little finger-like projections out one side of the cell. Here's the nucleus. And on the other end of the cell is something called the axon. Here's another nerve cell beside it. And maybe another one. Well, inside our nerve cells, we have vacuoles, little storage containers too. And inside the vacuoles are hormones. messengers, little chemicals that are in there. In the mood sensors, the centers of the brain, so those parts of the brain we've talked about, you know, remember the, again, so the executive center, right, in the anterior cingulate gyrus, the emotional memories, the hippocampus, the longer term memories, the amygdala, you know, the sentinel looking for stress indicators, and the pleasure center of the brain, and then the thalamus that's back behind there. These parts of the brain all connect with each other. They communicate with each other. Inside the vacuoles are these hormones. And the hormones in particular, we're talking about the parts of the brain that regulate our mood, are serotonin, noradrenaline, I'll underscore nor, N-O-R, noradrenaline, because I don't want you to confuse it with adrenaline, because adrenaline is that stress hormone that gets released. Noradrenaline is a hormone that's getting released actually when you're feeling calm and relaxed and feeling good. Dopamine and glutamine. Now there's, as I mentioned, there are lots of hormones in the brain, but when we're talking about the mood centers of the brain, these seem to be particularly important. And we know that their release, the release of these from these little storage containers, the vacuoles, out and going across the cell membrane is really determined by our genes, our genetic structure. So if you inherit genes that facilitate or encourage the release of these hormones, then you're less likely to suffer from depression or anxiety. When the little molecules get released, there's this particular signal. I'll explain in a minute what that is. But when this particular signal comes across to this cell, it opens up their little vacuole here and releases the hormone. And then in the membrane of the cell, the cell membrane, are transport systems, like little trucks that, you know, get loaded up with the hormone and then pull them across out here and pull them across the cell membrane. And then kind of launch them out into this space here. This space is called the synaptic cleft. It's a big fancy word, it's just a space. And I want you to picture it as like a body of water, like maybe a lake or an ocean or something. And these little molecules, as they get launched out here, are like little boats that are getting launched out into the sea. And then they float across, and they float across to this nerve cell. These finger-like projections, these dendrites at this cell, have little receptors on them. And the little receptors are like harbors. And these little molecules click in to these harbors. And the little molecules are just the right shape, and they're kind of like a key going into a lock. They're just the right shape to click in and attach to these receptor sites. When you get enough of these receptor sites inhabited by these molecules, these little boats, enough of these harbors filled up with these boats, it actually begins to pull apart openings or tracks in this cell membrane that allows positive ions. So what's a positive ion? Something like calcium, which has a double positive charge. It gets pulled across the cell membrane. Sodium is a single positive charge. Because the inside of the cell is generally more negatively charged. There are more negative ions in there. And so there's this electrical gradient that is set up across the cell membrane. But when the channels open up, positive ions move across. And then the electrical difference between what's the inside of the cell and what's the outside of the cell begins to change. And it really helps send an electrical message across that cell surface, which is the signal for these vacuoles to release their hormones. And then these hormones get released, and these little transport systems pulls them across, and they go and activate the receptor sites on this one. This is how nerve cells pass messages from one cell to another. And then after the little molecules have done their job, then they float back to where they came from, and there's a different transport system that pulls them back in here and puts them back into the storage containers. So what we know is that certainly some of the genes code for actually, it may not be the absolute amount of these hormones that are available in the vacuoles, the storage containers, but it may be more likely the transport system that is involved. Or it could be a combination of things. Maybe you don't have enough of these hormones inside the cells. Maybe your transport system, those little trucks that carry them across, maybe they're breaking down and there's not enough of the trucks to move them along. And so you don't get as much of the hormone launched out. And so you don't get the same messaging from one cell to another, and then you get reduced kind of electrical activity almost across that wiring system that connects these parts of our brain that regulate our mood, and we're more likely to suffer from depression or anxiety. There's another area of research that's come up in the past 5 to 10 years, and that's the area of medicine we call immunology. So what's immunology? That's that part of medicine that really looks at, in particular, inflammatory disorders. So what's an inflammatory disorder? An inflammatory disorder is where there's a disorder that causes inflammation. So we have things like lupus, ulcerative colitis, arthritis. These are medical disorders where there's inflammation. And it appears to be driven by the body's own immune system. You know, you've got these little cells floating around our body, like lymphocytes and neutrophils, that are part of our inflammatory response to gobble up bad stuff. You know, bacteria or viruses, and it's great to have them to help fight infections. But if they turn on our own cells and start to gobble up our own cells, then we get we can have an autoimmune disorder where our immune system's battling against itself. Immunologists really, their area of study is really looking at the whole area of inflammation and certainly autoimmune disorders that in fact emerge. When they look at inflammatory disorders, they can detect whether there's inflammation going on in the body, because inflammation is a complicated process in terms of we've got to increase blood flow to an area, and then we've got to send lots of little neutrophils and lymphocytes in, and then we have to release histamine, that dilates the blood vessels further, and there's a whole cascade of events that go on when inflammation occurs. And there are a couple of things that get elevated, a couple of chemicals that get elevated in the body when inflammation is going on. There's something called C-reactive protein. There's something called interleukins, interleukin 6s, 12s. There's different interleukins. These are all little chemicals that help facilitate the inflammatory response. And so if you have an inflammatory disorder, then we know that these markers get elevated. Well, what they found in people who are dealing with depression or anxiety is, guess what? Their inflammatory markers, their C-reactive proteins, interleukins are elevated. When people are suffering from depression or anxiety, there's an inflammatory response going on. So now we understand that with depression and anxiety, there's a genetic basis to it. We know from diagnostic imaging studies, we're getting reduced blood flow, reduced glucose, or increased glucose in other areas of the brain, differences. And recent MRI studies are showing we also are getting swelling in different parts of our brain. We're getting swelling in the anterior cingulate gyrus up to 50% bigger than normal size. This is going to correlate with inflammation. We also know we get swelling in the hippocampus. But with chronic depression over a long period of time, the more someone's been depressed or anxious over many years, we actually begin to get shrinkage of the hippocampus. And what they found is there's scar tissue. It's getting scarred from the inflammation. And we can detect and correlate long-term untreated depression and anxiety with loss of hippocampal volume, reduction in the size of the hippocampus because of the scarring that's going on because of the inflammatory response, most likely. We also know that the amygdala gets increased blood flow, increased glucose metabolism, and it gets swollen about 50% bigger than normal size. So that could be blood flow, could be inflammation, but we know that there are these physical changes that are occurring within the brain. The standard MRIs we have at the hospital can't show the kind of detail we need to show that, but in research settings, with MRIs that, in fact, have a higher resolution power. We're beginning to see swelling, and we can pick it up. Maybe one day when we're trying to diagnose depression or anxiety, we'll have access to a piece of diagnostic equipment that can just allow us to take a diagnostic image and actually show you, oh, here's a normal brain, and then here's your brain, and see where this is swollen? And you go, whoa. All of a sudden, your depression or anxiety will begin to have more meaning. I mean, you begin to think, yeah, oh, gee whiz, it is like a medical disorder that I've got. The next question is, so what causes the inflammation? And certainly we know that our stress hormones, cortisol and adrenaline, are good things for the fight or flight response. But if we don't burn them off with the fight or flight response, they can in fact become toxic to our body. They can cause inflammation to our coronary arteries, perhaps. They can suppress our immune system, so we're more likely to suffer from infections. And perhaps, maybe we may even be more cancer prone over time. We don't know that at this point in time. But if the immune system's suppressed, especially the killer T lymphocytes, one particular part of the immune system that's there to gobble up all the bad guys that get into our body. And if that gets suppressed, we could be more vulnerable to a number of things. We know that people who suffer from depression or anxiety are more prone to certainly infections and things. We know they're more prone to cardiovascular disease, which is the inflammation within our coronary arteries and stuff. But these hormones, it appears, also go into our brain, this cortisol and adrenaline, into our brain, and may be part of the reason, maybe part of the cause of the inflammatory response that occurs in different parts of our brain and the swelling that goes on when we're dealing with depression or anxiety. So again, another line of research that shows us that depression and anxiety are physically based disorders. Now, remember I said that a lot of people, often will say that they've heard that depression and anxiety are chemical imbalances. So there's some truth to that, because the chemical imbalances could mean we don't have enough of these getting released to pass messages across these parts of our brain that regulate our mood and keep anxiety under control. Or we may have too many of the bad hormones. These bad hormones, we can't really call them bad hormones because they're useful to us, but these stress hormones, cortisol and adrenaline. And I'm sure there are differences between people and how much of these hormones get secreted from their adrenal glands. So if you have genes that code for a lot of those bad hormones, not enough of the good hormones, you're going to get a double whammy. You may be more vulnerable. And then depression can be seen as being a result of our genetic legacy, what our genes have, but also what kind of life stresses we have that are going on around us that are going to crank up our cortisol and adrenaline secretion. So I'm a pretty resilient guy, but if you put me in a concentration camp and shoot my family in front of me, my stress hormones are going to go up through the roof. And then I may not only just may grieve the loss of my family, but may develop a major depressive disorder as a result of that cortisol and adrenaline getting cranked up into overload and contributing to an inflammatory reaction within my own brain too. Okay, so that being said, we understand that depression and anxiety are sort of physically based disorders. But maybe we should have called them something different so we respect them more than we have today. And maybe that's one of the reasons why mental health has had the stigma, because we have not really understood the physical nature of depression and anxiety. That being said, how do we treat it? We have a number of treatments. Depression and anxiety are tough disorders to treat. We don't have a magic bullet yet. But we have a number of interventions that, in fact, can be very helpful for us. Coping strategies. What are coping strategies? Coping strategies are things that help us deal with stress or decrease moods. We've all got different coping strategies. So what works for you may not work for me, or what works for your sister may not work for you. We all end up doing things when we're under stress to try to relax, right? Like you may have that pizza on a Friday night, right, with a glass of wine, right? So what does that do? I mean, well, we tickle our pleasure center of our brain, so that's good. We get more electrical activity going on in the pleasure center of our brain. And the more that striate body, the pleasure center, gets activated through those things, it sends messaging out to the other parts of our brain that regulate mood and activates them. So that's good. So coping strategies like going for a walk. Going for a walk can be relaxing for some people. We encourage people to do things like slow, deep breathing. When we do slow, deep breathing, a lot of things happen in our body. Our diaphragm goes down, we activate something called the vagal nerve. And the vagal nerve, when it gets activated, reduces pulse rate. Your heart starts to slow down. It reduces a feeling of shortness of breath in your lungs, so you feel not as short of breath. It slows down the secretion of adrenaline and cortisol out of our adrenal glands. So it's kind of reducing some of those bad hormones. So that's a good thing, right? Well, I feel stupid if I have to go do slow, deep breathing. Well, yeah, okay, but think of athletes. So when athletes, I like to look at the Olympic skiers, you know, as they're getting ready to go down a slalom run, and they're in the chute, and they're getting ready to, before the bell goes off to indicate their takeoff time, you see them go, what are they doing? They're actually reducing some of their cortisol and adrenaline secretion. Because if we get too high levels of these, we start to lose motor coordination. Our muscles start to overreact. They get too twitchy. So you need to be relaxed. You need to be focused and have some adrenaline up to activate you, but not so much that you start to get uncoordinated, right? You have those times, you remember those times you played a sport, you know, and it's an important game or something important's going on, and you go up to do it, and you feel your body's just not moving the same way, and you screw it up. Right? You see professional athletes making a mistake, think, oh, how did he do that? Well, yeah, cortisol and adrenaline. So getting cortisol and adrenaline under control, slow, deep breathing can do it. You see a baseball pitcher, before he gives the pitch, he winds up, he looks over for someone on first base, then he has a big deep breath. And then he delivers his throw, right? Slow, deep breathing. There are things to do to help try to regulate the release of these. Listening to music when you're having a stressful day. I mean, it's really nice sometimes, you know. Some patients love heavy metal music and love banging their head around, you know. I like to listen to Chopin, right? Just quiet piano music playing, watch the snow coming down outside, have a fire. You know, whatever turns your crank, whatever does it for you to help reduce your cortisol and adrenaline. And pleasurable things that we like also turn on the pleasure center of our brain. We get more hormone release out of our striate body. So coping strategy, we need to learn coping strategies. When patients come on our unit, we want to make sure they have at least 4 or 5 coping strategies they can use. They can use these, you know, out in public. We need some casual things like slow, deep breathing. If you're in class at school and you're sitting there going, your friends are going to look at you like, what's wrong? What's wrong with you? You look kind of goofy. But you can do it very subtly, right? You could do a slow, deep breathing like, and people won't notice. Something you can do right then out in public. Then there's some things you can do in your own home, like having your comfort food, playing with the dog if you've got a dog. You know, I love seeing my dog come home at the end of the day, comes up wagging and licking me all over, and I start to feel really good. It's a coping strategy. Go play with the dog. Listen to music. Paint. Video games for a lot of teenagers, right? Pleasurable in the pleasure center of their brain. You know, yeah, I got that one. Yeah, I got that. Oh, you know, it's like your adrenaline's getting cranked up a bit, but you're getting probably increased releases of these hormones connected out of your pleasure, out of your striate body, going across activating your system. So coping strategies. What else do we like to focus on for treatment? We talk about cognitive behavior therapy. So what's cognitive behavior therapy? Well, actually, it's what a really good grandmother would do for you. So what is that? Well, want to change your cognitions. The C in cognitive behavior therapy stands for cognitions. These are your thoughts. So where are your thoughts? Aha. Remember that executive center here in the brain? Dorsolateral prefrontal cortex, the Oval Office, the president's in there. Yeah, let's get Obama in there. Let's get positive thoughts in there. We know that the more positive thoughts that get emitted in this part of your brain, the more we increase the release of these. And just think, if you start thinking negative thoughts, you think about all the things that are going wrong in your life, what's going to happen to the release of these out of your adrenal glands? They're going to go up, right? Yeah, they're going to go up. So we want to change our thinking. We want to learn how to change our thinking. We want to learn how to recognize when we're into negative thought loops and patterns, and we want to change those because we can change the hormones in our brain. We can actually change the release of the good hormones in our brain and reduce the bad hormones just by our thought content. And you know that. You have a good coach who inspires you to take chances, right? You can do it. Great effort. Love the way you did that. You know, you do it more. You work harder. Most of us don't respond well to coaches who say, oh, you're terrible. You're useless. You know, I mean, some people need to have a fire line under their butt to get moving. Some people need to get this activated. Some people do respond to some, you know, a coach who really criticizes and provokes them because you want to prove the coach wrong, right? But most of us don't. Most of us respond to those positive thoughts. So again, cognitive behavior therapy, seeing a counselor who helps you learn how to coach yourself by recognizing when you're into negative thought loops and changing them. What's the behavior in cognitive behavior therapy? Well, that's making sure you make behavior choices or decisions that are life enhancing. So say you're nervous, you're suffering from anxiety and you don't feel so good, you got poor self-esteem, and your friend says to you, oh, we're having a party over so-and-so's house one night. And you say, oh, okay. And they ask you if you want to come over. You say, well, who's going, right? And you find out one of the people that's going is this nasty person you don't like so much. You think, oh no, I don't know if they're going. But you don't want to say it, so you start coming up with an excuse. Well, no, I've got something I got to do that night, boom, 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 boom. And so you don't go. And then on Monday morning, you come back to school, and you start, or nowadays, not even Monday morning, Friday night, people are messaging you and Snapchatting you and showing these pictures of people having a great time. And you're thinking, oh, I should have gone to that. You found out that person you didn't like wasn't even there. It's like, oh. So it's like helping you reflect on decisions that you're making to make sure that you try to make decisions that are life enhancing for you, rather than just making all your decisions out of fear or anxiety, trepidation. Trying to help you make better decisions about what you do in your life, so you have more positive experiences, so that your pleasure center in your brain is getting enhanced, so that your sense of mastery and being able to cope is enhanced, so your self-esteem comes up, right? So cognitive behavior therapy. Aerobic activity. So what's aerobic activity? Cardio, got different names for it. It's getting your heart pumped up and getting you breathing hard. So why is that important? Well, let's think about that. Remember those bad hormones are secreted for the fight or flight response? But I said if they don't get burned off, then they can contribute to inflammation within your brain and the mood centers of your brain and make you more depressed and anxious. So cardio, what does it do? It burns off the bad brain hormones. It burns these off the way nature intended them to be burned off. But we also know from recent research that aerobic activity also stimulates the release of our good brain hormones here. Serotonin, noradrenaline, dopamine, glutamine. But more than that, aerobic activity also increases the release of endorphins and enkephalins in our brains. These are feel-good hormones. These are like the brain's own natural Valium that help you feel calm. If you've taken part in a physical activity and afterwards you're tired, but it's a nice tired. It's not like stress from work and you get home and you're worn out. it's not as pleasant a feeling. But after physical activity, there's this pleasure thing. It's the endorphins and enkephalins are getting released. But aerobic activity also stimulates the secretion of things that reduce inflammation. We have something in our brain called brain-derived neurotrophic factor. What's that? BDNF. It's a hormone that gets released that puts a protective coating around brain cells so you don't get inflamed. So aerobic activity helps reduce inflammation by doing that. Aerobic activity also increases the release of anti-inflammatory cytokines. These are other little inflammatory chemicals that suppress inflammation. Aerobic activity increases the secretion of those. Aerobic activity suppresses the release of pro-inflammatory cytokines, reduces inflammation. And over the past 4 years, we've also found out that aerobic activity increases the release within our brain of endocannabinoids. Now, most teenagers get interested hearing about that term, cannabinoids. Well, I'm not talking about cannabinoids as in weed on the street. Weed on the street has, hundreds of active metabolites, but our body produces 2 of those itself. Our brain produces its own cannabinoids. In our brains, we have CBD1 and CBD2 receptor sites. But aerobic activity increases the release of our own endocannabinoids. Endo means inside the body, endocannabinoids. So aerobic activity is very powerful in that it burns off the bad brain hormones, increases the release of ones we know correlate with mood, but also a whole bunch of other hormones that help protect our brain cells and give us a sense of pleasure and release. So aerobic activity. Now I know when you're depressed or anxious, the last thing you want to do is get on your jogging shoes and go for a run, because many times your energy is low. But we want to encourage you to start. Start with where you're comfortable. We want you to start with an exercise program that you can do. I don't expect you to go out and run 10 miles every day to start. But certainly setting up a walking program, starting off slow, but gradually increasing the intensity over time. This is something you should build into your life on a long-term basis. So if it takes you a year and a half to really build up your exercise capacity, that's okay. When people start exercise programs, out of 100 people who start, 97 people drop out. And why do they do that? I think many times they do that because they push themselves too hard, too fast. And we want you to build this in your life as a lifetime event. I suffered my first episode of depression when I was 20. And in those days, they didn't know much. I played a number of sports through high school, my first 2 years university, football and hockey. And then my grades weren't where I needed to be, so I pulled out of my sports and my mood just dropped down. I saw this psychologist, and he said to me, "Boy, you should be doing something active." And he said, "Why don't you start a running program?" I thought, "Oh no, I like playing a sport, but I wasn't so keen on just running." Anyway, but he started me off. He ran. I started running with him. So I started that when I was 20. So I've carried it through right to this day. I have a workout program. I usually do an hour and a half. I try to do it 7 days a week. I usually get 6 days a weekend. So I'm 70 years old now, so I've been doing that for 50 years. So, and I know for me and my family, I'm one of the few people in my family who didn't have to be on an antidepressant. Stay on an antidepressant medication. Because that exercise program, and it's also, because it helps your cardiovascular system, helps your immune system, helps you in all kinds of other ways. So, but I want you to think about that. This is really critical. If you're dealing with depression or anxiety, it's something you got to build into your life. The next treatment area is activation. What does that mean? Well, activation means trying to stay active in your life. It means not laying down and letting depression roll over you like a steamroller, or not letting the anxiety in your life, the fear of things happening, the fear of something going wrong, stop you from engaging yourself in activities that can bring pleasure and a sense of competence and accomplishment to you in your life. It's really important you keep putting one foot in front of the other, even when you're depressed. When you get up in the morning, when you're suffering depression, that's often one of the worst times of the day, dragging yourself up out of bed. I call it psychological inertia. It's like pushing a car out of a ditch. It takes a lot of effort to get the car moving. Once it's moving, you can push it along pretty easily. But getting started, getting the day started, and putting one foot in front of the other is really important in terms of keeping yourself mobile and keeping yourself activated and giving yourself opportunities to be successful. Fifth area, medication. Antidepressant and anti-anxiety meds. So what do? Well, I've told you about these brain hormones, and I've told you about the fact that they get released from one cell to float across here like little boats going across, line up at these getting connected into these harbors, and then going back. And if you're suffering depression or anxiety, you're likely not releasing enough of these hormones, or you don't have enough of that hormone available to you. So how do antidepressants work? Well, we have antidepressants that are specific for different brain hormones. We have antidepressants that are called SSRIs. And what does SSRI stand for? It's serotonin-specific reuptake inhibitors. Well, that's a bunch of words. What do those words mean? Well, remember, after the molecule of serotonin has done its job, it goes back, and there's a transport truck that pulls it across and puts it back into storage. Well, the serotonergic-specific reuptake inhibitor takes the key out of that transport truck, so it can't transport the little molecule of serotonin back in and put it back into storage. The molecule can't get back in, so it comes back across here and reactivates the receptor site on the other side. So the antidepressant SSRIs work just by allowing your own serotonin to do a better job. We have antidepressants that are SNRIs, serotonin and noradrenaline reuptake inhibitors to help increase serotonin and noradrenaline. We have antidepressants that are dopamine reuptake inhibitors. We only have one really that's working well at this point in time. That's something called Wellbutrin. And then we have something called multimodal antidepressants. These are antidepressants that increase, or that block the reuptake rather, of all of these hormones. So they work on all these. Usually we start with the serotonin-specific reuptake inhibitors because they have the gentlest side effect profile. The more of these things we begin to activate, common sense tells us the more likely we are to have side effects emerging. And we don't know, and we can't tell at this point in time. Maybe later on we'll be able to take a little scraping out of the inside of your cheek or a saliva sample. We can be able to do genetic analysis and know whether you're someone who's more serotonin deficient or whether you're more noradrenaline deficient. In fact, there's some research being done now to do that. But right now it's just trial and error. So we start with these ones, then we go to these ones, and then add these ones, and then add these ones on. Unless we know someone in your family biologically has suffered from depression or anxiety and they've responded to a specific antidepressant. Remember, genetics, DNA, we know that some people respond more commonly. So that's the ones we'll start with first. But the best outcomes when we're dealing with depression and anxiety are when we use all of these things together. We don't have one magic bullet yet that does the whole job by itself. We often need to use all of these. So again, summary, depression and anxiety are biological disorders that correlate with our genetics, can also correlate with life stresses that we're dealing with. It's not because you're a wimp. It's not because you have a character flaw. There is a chemical imbalance, not enough of the good ones, too much of the bad ones. But they can be treated. But it's a full multimodal approach in terms of how we treat depression and anxiety.